Yeah, cheers, Eddie.
Hello.
Welcome. Hello.
Hi.
Hello, everyone.
Hello, Anna.
Hello.
We're just letting people in. We are slightly behind schedule because our speaker, Jake, unfortunately is experiencing a few Wi-Fi issues. So we thought we'd let you in and kind of start with some sort of explanation and introduction, and then hopefully Jake will be up and running and ready to join us by the time we've finished that. We didn't know how many people were new to Sport for Confidence, new perhaps to the Moving OTs network and these kind of evenings. Yep, Angela's telling me she is. So I thought it might be quite useful to start with a bit of an explanation of Sport for Confidence and the Moving OTs programme. So before I start, I'll just quickly introduce myself. My name's Anna Pettican. I'm one of the occupational therapists at Sport for Confidence, and I also have an academic role at the University of Essex where I teach and do research. Liz?
Hi everybody, Liz Fletcher, occupational therapist and lead the national team at Sport for Confidence, and part and parcel of helping create Moving OTs network, as we believe in occupational therapists using physical activity as a therapeutic and assessment tool, and would like ideally every occupational therapist in the country to be thinking in the same way that we do. I did notice, by the way, that Shannon had her hand up, but it's gone down. But Shannon, if you want to speak up, you may.
I was just saying I'm new to this kind of thing as well. That's all. Thank you.
Okay, Andy?
Hello, everybody. I'm Andy. I'm also an occupational therapist who works at Sport for Confidence, based in the national team, and I'm also based in the north of England, like Liz. Hello, everybody.
So Sport for Confidence, for those of you that don't know, is a social enterprise that was founded and is run by an occupational therapist, Lindsay Barrett. And the main part of the organisation, I guess, initially was around developing a model that involved placing an occupational therapist and a sports coach into leisure centres to make them more accessible and inclusive. And that's continued and evolved over recent years. So we're now in something like 13 leisure centres, is it, Liz? I can never remember exactly, throughout Essex and Greater London. And that number kind of keeps increasing all the time. But additionally now, and in addition to that, what we refer to as delivery work, we also have a national team that Liz mentioned earlier. That's funded via a system partnership with Sport England. And as part of that, we have an initiative called Moving Occupational Therapists, which kind of promotes the use of physical activity for therapeutic means and ends and assessment purposes within occupational therapy practice. And the important thing about that initiative is it connects us up with a wider programme called Moving Health Professionals and also Moving Social Work, because there's sort of various separate sort of disciplinary approaches and pieces of work that are going on. So, Jake, how are you doing now? Are you all okay with Wi-Fi? I can see you outside now.
Can you hear me? Can you see me?
We can hear you. We can see you. That's brilliant. Thank you. And so tonight, I'm really delighted that we've got Jake with us. Now he's got his Wi-Fi problem sorted. And Jake Netherway is a PhD candidate at Durham University, and he's undertaking research that will particularly inform the Moving Social Work initiative that aims to develop social work education and practice to better promote physical activity. But kind of inevitably, really, some of Jake's research findings that he's developing also relate to more widely to other disciplines such as occupational therapy. So that, in a nutshell, is why we've invited Jake to come along and speak tonight, and hopefully also have some discussion time with us to think about how some of his research findings might be relevant to us in our work as occupational therapists. I think the other thing to just say really briefly before we start, which is something Jake and I talked about when planning this session, is That we're also particularly mindful at the moment that we've had new standards of proficiency published by the Healthcare Professions Council. They don't actually they're not actually implemented until September, but they are available on the HCPC website if anyone wants to look. And I think what's really important about those new standards is there are now standards I can never say that word, particular standards around public health and preventing ill health. So that's really important for us as a profession, and certainly that's where we sort of see this work as fitting in terms of our sort of professional registration and those kind of expectations around our practice that come from HCPC. So if people are sort of interested in thinking about our role in public health and how that fits with physical activity, I'd say take a look at those new standards, might be relevant. But without any further ado, I'm going to hand over to Jake, if that's okay, Jake.
Fabulous, thank you. Now I'm just going to pray that presentation shares. My Wi-Fi doesn't drop out, so I'll share it, and then I hope someone can tell me that it's
For
working.
those of you who've just joined, Jake's had a bit of a nightmare with Wi-Fi, so yes, great. We can see that, Jake. Everyone can see that.
Right.
Brilliant.
Halfway there.
Thank you. So how long are you going to present for, Jake? And then we're going to have a bit of discussion time afterwards, aren't we?
Half an hour, give or take.
Okay, brilliant. So about
Okay.
half an hour. And we are recording, people, just to let you know. It should be at the top of the screen, but we are just recording this as well. Okay, thanks, Jake.
You can see me okay?
We can see you fine, and we can see your presentation.
Okay, if I just flick through, just so you can tell me. Is that flicking through?
Yes.
You absolute star, Anna. Thank you very much.
All
Okay,
right.
well, I'm sorry I missed the introduction to everyone. But yeah, hi, I'm Jake, and Anna's introduced me, but I'm a PhD candidate at Durham University, and my research interests are in physical activity promotion, disability, and reducing health inequalities. And I really do apologise if my Wi-Fi cuts out. I live in the middle of nowhere, and I'm borrowing my dear neighbour's Wi-Fi in the last minute plea. So I'm sat in his front garden. So if I go, that's why. And if you hear any background noise, he has a lovely dog, so there might be some barking. But as Anna said, I work on a programme called Moving Social Work. Moving Social Work looks to train the social workers of today and tomorrow on how to promote physical activity to, for, and with disabled people. And as part of phase 1 of Moving Social Work, we look to undertake this review, which I'll talk about shortly, to understand the landscape essentially in physical activity promotion and what we can learn from it, and then provide a context or a social work context to that learning. So we're not looking to reinvent the wheel, we're just looking to adapt it ever so slightly. Just checking I'm still here.
You're still here, Jake. You're doing fine.
Lovely job. Okay, so before I get into the nuts and bolts of the presentation, I'll try and... There we go. I think it's remiss of me to identify the problem of why this research exists in the first place. So we have a physical inactivity and sedentary behaviour crisis, both globally and nationally, whereby physical inactivity is the 4th leading cause of mortality, and it contributes, well, it has an economic cost of around $27 billion annually worldwide, with a 1 billion or near £1 billion cost to the healthcare service in the UK alone. And so one way of combating this inactivity crisis has been through the use of physical activity messengers. And by messenger, I mean a professional group, person, peer, or organisation who can deliver these messages of advice, of physical activity content and learnings to patients or to people that we support, to hopefully increase the levels of physical activity that they attain and hope to achieve moving forward. So this schematic is by Chloe Williamson. She's an academic at the University of Edinburgh, And in a nutshell, this framework looks at the who's, the what's, the where's, the when's, the why's, the how's, in terms of what messages should be delivered, by whom, and how often. And going back even further, I think it's appropriate for me to define what I mean by physical activity. Now, a lot of the literature defines physical activity by the World Health Organization's definition, which has been cited over 10,000 times, which they state physical activity is any bodily movement produced by skeletal muscles that requires energy expenditure. So this could be from movement during leisure time for transport to and from places, or as part of a person's work. So the focus is very much on moving, on energy expenditure and skeletal muscle. And that definition is quite important when I go on to reveal some of the findings from our research. However, as part of moving social work, we look to use a more recent adaptation to physical activity, which was by Joe Piggin, which defines physical activity as people moving, acting and performing within culturally specific spaces and context, influenced by a unique array of interests, instructions and relationships. Now, personally, that fit really well within the social work learning and training that we're doing. However, I feel like this has an occupational context as well moving forward. So what I'm going to talk to you about today is essentially the findings of the scoping review, more specifically, Anna, what healthcare professionals of today and tomorrow are taught to promote physical activity and how this is done. Then I'll try and relate that to the limited literature that exists within occupational therapy and physical activity promotion. And then finally wrapping up, as Anna stated, how this relates to the recent revision of professional standards. So the scope and review that I'm alluding to for the next 15 minutes or so is published open access in the International Journal of Environmental Research and Public Health in 2021. And as I said, it was to discuss and learn as part of phase 1 of moving social work, just to understand the nature of physical activity promotion in the healthcare literature and try and translate these learnings across to moving social work. Just methodologically, why did we do a scoping review? Well, a scoping review is a more general, broad overview of the characteristics and traits and concepts of the research literature or the literature base, touching upon a lot of grey literature, which can include Sport England documents or policy documents, as opposed to a systematic review, which looks at answering the effectiveness or meaningfulness of a given intervention. So a scoping review is quite appropriate for this type of literature review. Typically, this is done in 5 stages, where we identify the aim and answer some research questions more broadly, look at what studies are out there in the peer-reviewed literature base and grey literature, chart them, refine them, and then collate, summarize, and report the results. So from this study, we managed to, as part of a search strategy, identify 3,500 papers, to which we whittled down to 25. That was a mixture of empirical evidence and grey literature found in sports policy documentation. And we looked to answer 2 predominant research questions in terms of what physical activity training content do healthcare professionals receive and how is this delivered. Now, as part of this refinement and investigation into the healthcare literature, most of the studies returned favoured or looked at medical students, GPs, physiotherapists, nursing communities and students, with very limited research to do with other AHPs, of which around 10% focus on occupational therapists. So the literature base for this in a specific occupational therapy lens is very small. However, I'm sure some of the learnings can be translated across. We're about 5 minutes in. Anna, are we still here? Can you still hear me? Are we all good?
Yes, I can still hear you. All good. Thank you, Jake.
Perfect. I don't want this to be an echo chamber. So to answer the first research question in terms of what physical activity training do healthcare professionals receive, we looked at this through 3 overarching themes. Now, these aren't really rocket science. They should be fairly straightforward to comprehend as to why these themes were incorporated into the training. But the first overarching theme was the health benefits of physical activity. Now, I've just pinched the schematic that we made as part of the scoping review. So if anyone's interested to delve into the finer details, as I said, the paper's open access, and I will provide a sharing link for this presentation. And I've hyperlinked, every image has a hyperlink to the given text. So see this as an opportunity for CPD as well, if you see fit and you like what I'm talking about. But in terms of health benefits, there's a large discussion on the importance of physical activity and then the actual health benefits of physical activity. And these should be known, but these include, by increasing physical activity, you're reducing sedentary behavior, which, as I've stated, is the fourth leading risk factor behind high blood pressure, tobacco usage, high glucose, and just in front of overweight and obesity. Physical activity or increasing levels of physical activity also improves muscle function and muscular adaptation, improves cardiorespiratory fitness, cognitive function. I'm sorry, there's no background noise. The drain is currently pouring water, so I do apologize. Improved bone health and functional health, in addition to reducing the risk of falls as well as any fractures, which I guess is very appropriate to OTs and working with some sort of populations. Furthermore, reducing inflammation and oxidative stress, weight loss and weight management, and improved body composition with reduced fat percentage or reduced fat composition, improved mental health, improved sleep quality, and management of long-term health conditions, which I'll touch on a little shortly. And how this is typically presented in the learning, in the training, is through the UK Chief Medical Officer's Physical Activity Guidelines. Now, the CMOs have published guidance or guidelines for adults, for children, for disabled adults, disabled young people and children, and pregnant women. And these are all available on the government website, but I've hyperlinked them into the given training programs. So alongside the importance of physical activity and the health benefits of physical activity, there's further training content which breaks down the physical activity benefits, or rather the benefits of physical activity, in three population groups: young people, elderly people, and disabled people. Now, many of these benefits are very similar to the ones I alluded to before, but I wanted to just pay particular focus on the further training content, which was the focus on certain non-communicable diseases. So that includes things like cardiovascular disease, diabetes, respiratory conditions like COPD, chronic asthma or emphysema, and some cancers. So from the training content, and due to the nature of time, I don't have enough time to go through each and every long-term health condition, but these are all available on the e-learning of the health, which I'll signpost in due course. What was interesting from the findings was that there was limited evidence or little empirical resource that discussed the socio-economic barriers to physical activity participation. And this is something that I do feel that occupational therapists and social workers, as part of my research, really touch on. And this is something that I'd quite like to discuss moving forward as part 2 of this presentation. So that's theme 1, the health benefits of physical activity. The second theme that was discussed as part of the training content was actually promoting physical activity within healthcare. So these are more the tools, the tricks, the actual application of how physical activity advice was implemented into routine healthcare by healthcare professionals. Again, these aren't really, there's nothing rocket science here, but it's essentially incorporating physical activity assessments through questionnaires, adding physical activity levels and physical activity behaviours through vital signs and adding them to patient health histories, assessing current physical activity behaviours using concepts such as the FIT principle, which is the frequency, the intensity, the time, and the type of activity that a person or a patient would engage in, and then identifying any risk factors or known risk factors that might make engaging in physical activity slightly risk-inducing. So these contraindications may include high blood pressure, tachycardia, unstable angina, or maybe unstable diabetes. Furthermore, there is training in physical activity prescription, which is typically a 12-week exercise prescription to a gym, which, harking back to the definition of physical activity, makes us question that there are wider determinants and wider incorporations of what physical activity means other than just the gym. So alongside adding health histories and patient information into their assessments, there are a certain framework that the physical activity training content does incorporate, and that's making every contact count. Now, I'm not sure if anyone's familiar with this or you're all familiar with making every contact count, or MEC, but it's essentially a concept revolved around nudge theory, which means simple, small, brief interventions made by many people can hopefully lead to aggregated changes in behavior. So making every contact count is derived at health professionals to change or encourage behavior change by their patients. And MEC is an overarching philosophy that we use as part of movement social work as well, that it should not just be healthcare professionals who incorporate physical activity advice and physical activity training into their current curricula. Furthermore, when giving this advice, we look at two different frameworks. The first being the 5 A's framework, which looks to ask the patient or the person what their physical activity behaviours are at present and how this might change, or whether they even want to change their levels of physical activity. Assess whether it's feasible, whether it's safe for them to do so. Advise how to increase levels of physical activity based on your knowledge of the health benefits, the importance of physical activity, and then the known guidance as outlined by the CMO guidance, and then assist and arrange that to happen with follow-ups from the healthcare professionals to assess behaviour over the long term. Furthermore, especially when arranging this kind of physical activity behaviour, we look to a LEAP framework, which is activities that are local, they're enjoyable, they are affordable and practical. And when you're signposting, or when healthcare professionals were signposting, the training indicated free activities, often community-based activities, including parkrun, walk for life, and daily mile. The final theme that was included in the training content outlined in this review was behaviour change, physical activity and behaviour change. And as part of the CPD training, less so the undergraduate education that students received, this was focused on something called the COMBI model, which looks at a person's capability, opportunity and motivation to change their behaviour. Now, one way of assessing and understanding a person's capability, opportunity and motivation was to use a tool called motivational interviewing, which includes asking reflexive listening, asking open-ended questions, and linking the discussions and the conversations to that patient's goal. The final aspects of this training and the training content that was included patient case studies as a way to understand, assess, revise, and examine your learnings, to put it into the context of a person that you're supporting, and then to answer questions based on their given histories. So that would include things like elderly lady with tachycardia, wish to get more active. How would you go about incorporating conversations around physical activity into a given conversation? One thing that we did find, and this was supported by 2 stakeholders who were involved in the Moving Healthcare Professionals programme, which is where the majority of this training surrounds and incorporates, stated that it lacked a patient voice within these case studies. So this was done this was produced through the evidence base on the healthcare literature, similar to what I'm talking about now, and that the health history and the social determinants of health and physical activity were perhaps neglected in these patient voices. So again, an interesting insight for future research and development of these interventions and training resources. So that's the content. To answer the second question in terms of how this was delivered, 3 overarching means or methods was achieved in this. The first one being e-learning, which I'm sure most of you are familiar with. 4 overarching modules or what's the word, programs were used for this. BMJ e-learning, which again is free to access, has 9 modules on promoting physical activity in primary care. E-learning for health has 2 modules, 1 short course, a 2-hour short course, or a 9-hour, it might be 8 hours, 9 hours, 11 modules, healthcare and promoting physical activity within healthcare module. Moving medicine, which is also part of Moving Healthcare Professionals Programme, is a fantastic resource which offers short, medium and long-term conversations through 1 minute, 5 minute and more minutes conversations about how to promote physical activity in relation to specific long-term health conditions, which I alluded to back in the training content. Finally, we've got the British Association of Sports Medicine's Motivate to Move, which has 18 modules focused around physical activity promotion. This one was tailored specifically to physiotherapists, but the learnings are quite translatable. Alongside e-learning, we have face-to-face learning. Typically, this comes through protected learning time for healthcare professionals and peer-to-peer contact via clinical champions. Now, I'd be interested to know if anyone on this call has experienced or are a Moving Healthcare clinical champion and your experience of said program, but it's typically an 1.5-hour session to discuss some stories as well as a slide set around the benefits of physical activity. And finally, we have a blended approach, typically seen in the Movement for Movement resources developed by Anne Gates, which have been embedded in the undergraduate curriculum and also housed on online portals. And blended learning presents a real opportunity, as I'm sure everyone on this call are aware. So that's the 2 overarching questions. What key findings did we find from the scoping review? Well, there's 6 that we can allude to. The first being that there's no standardized approach to physical activity training within healthcare professional education at present. It's a bit of a ramshackle in terms of what can be achieved where and when, especially in the student population and the undergraduate curriculum, where it's sort of pushed in as an add-on or a bolt-on rather incorporated as a key tenet of a person's education. Now, this might differ in the next few years when we look to disaggregate these learnings across professional groups. So this is Moving OTs, and as I've discussed, Moving Social Work can provide different contexts and different learnings to specific occupations. Second key finding is that typically the training here alludes to an epidemiological approach to physical activity promotion. What I mean by that is talking about the health benefits, so the physiological health benefits of being or increasing physical activity, more so than the social determinants or the social benefits, such as improved quality of life, sense of purpose, social inclusion, that I feel like you as an occupation or occupational therapist may see in your day-to-day practice, more so than a GP, nurse or physiotherapist. A further finding is that learning experience and opportunity for blended learning presents a real opportunity for interactions such as this one we're having today to go with core curriculum housed online or on e-learning platforms that you can do as you go at home or in your own approach. We've also seen certain case studies of a flipped classroom approach, whereby typically students do their homework at home in class and do the key tenets of the learning resource at home. So you bring in your learning to discuss the findings as opposed to the other way around. The fourth key learning that we've identified through this scope and review has been that there's a real lack of patient voice in the learning so far, and that narrative medicine storytelling present a real opportunity to provide a pedagogical learning opportunity, as well as incorporating public and patient involvement into the actual learning from and of healthcare professionals. Fifth, suggestions that the medical curriculum is already, so this was more specifically to.
Oh, I'm losing you a little bit, Jake.
Student.
Oh, we're losing you a little bit, Jake.
activity. So, if I keep going, can you cut in and tell me I'm losing it again? Okay.
Yeah, you're clear again now. Could you start again just from the start of the medical curriculum is full findings? I think that's where we lost you, Jake. Sorry.
Yep, no worries.
Thank you.
So, yeah, so one of the key findings here was that essentially the medical curriculum is already full and that there's no room for physical activity promotion to be incorporated in it as a standalone module. So one approach to overcome this has been to embed it in a spiral approach or a spiral curriculum, whereby physical activity is dropped into certain modules, such as the teachings around certain non-communicable diseases and the benefits of physical activity in tackling, maintaining, and in some instances improving these long-term health conditions, as opposed to standalone physical activity promotion modules. You still got me, Anna? We're still here?
Yes, thank you. You're still there.
Perfect. Final finding and final theme from the scoping review was that it's not just healthcare professionals. As part of MEC, as part of moving OTs, as part of moving social work, healthcare professionals should not be the only messenger of physical activity promotion. And this was a call to action for ISPA, which is the International Society of Physical Activity and Health, to expand their message that healthcare professionals are credible, trustworthy messengers, and expand this to other health and social care workers and professional groups so that we can encourage MEC, encourage making every contact count, and ultimately increase behaviour change or physical activity behaviour change in people and in patients. So how does this relate to occupation? Well,
We're losing you a little
went
bit
back
again,
and conducting
Jake.
evidence that wasn't included to publication date, and there's very little, to be honest, about physical activity promotion. No. But 1, 2, 3, 4, 5. Can you hear me?
Yeah, we've still got you at the moment, I think, Jake. Thank you.
I'll keep going. I'm nearly there. So, to allude to the literature in relation to occupational therapy, there's very limited evidence or very limited empirical evidence about physical activity promotion within occupational therapy. So in terms of looking about what is already known, one study, Cunningham and O'Sullivan, looked at OTs in Northern Ireland 2021 to see what the existing knowledge base of occupational therapists were in relation to physical activity, and only 60% were aware of the content and the objectives of the national guidelines, of which they asked what those guidelines were. Only 29% of OTs in that study could answer correctly what the guidelines were for moderate physical activity, only 11% for vigorous physical activity, and 27% for the frequency or number of days for strength, balance, and flexibility training for health benefits. Furthermore, only 33% of OTs in that study were aware of the resources to increase their knowledge and capability of physical activity promotion. So why might this be relevant to OTs and to occupational therapy? Well, the moving healthcare professionals training has resulted in sustained number and duration of physical activity conversations had with patients. So essentially the training works, and that it's recommended that you enroll. And so there's multiple ways to do so, which has been the e-learning platforms that I've identified through BMJ Learning, e-learning for health and moving medicine, or taking part in a clinical champions training session in physical activity promotion, or as an undergraduate student to investigate movement for movement, which has been sent and disseminated to every medical and health school in the UK in respective universities. And so finally, the relevance to OTs is that as part of the sports and exercise medicine pilot, recommendations were for OTs to be the next clinical champions. So again, if there's any clinical champions on this call, very much like to hear from you and your experiences of being a clinical champion or attending a clinical champion session run by another healthcare professional or AHP. One final concern or consideration for this context of relevance to OTs is that you're preaching to the choir, and that physical activity is already an important aspect of the professional competencies and practice, and that includes physiotherapists as well. So finally, as Anna alluded to at the very start of this presentation, the revised standards coming in September 23, and in particular standard 15 of promoting public health and preventing ill health, outlines 4 new standards, of which 3 I would consider relevant to occupational therapy and physical activity promotion. So that is including standards 1, understanding the role of profession in health promotion, education, and preventing ill health, whereby increasing knowledge, competence, and skill to promote physical activity would encapsulate that standard. Understand how social, economic, and environmental factors, so essentially the wider determinants of health, can influence a person's health and well-being. And I'm well aware that OTs have that in abundance, that awareness of the wider determinants of health and accessible environments. Again, physical activity falls into this standard very, very well. And finally, empowering and enabling an individual to play a part in managing their own health. And physical activity is one way of doing so, by promoting sustainable, local, enjoyable, practical, and affordable physical activity opportunities that can be built up incrementally over time. So that's the finding of the scoping review. And I think I've just about made it through without cutting out too much. But before I end, I have some discovery questions that I think would be quite interesting to discuss in part 2 of this workshop or discussion, in terms of, as a profession and as a group of occupational therapists, should you be promoting physical activity? What are your views on that? Do you feel like you already have the knowledge and skills to promote physical activity? And my question to you is, are you aware of the National Physical Activity Guidance? And if so, what are and what is the National Physical Activity Guidelines in terms of moderate and vigorous physical activity, and how many days strength, flexibility, and balance training should a person do to accrue health benefits? And does this align with your professional standards? And if not, how? And finally, does your training already incorporate physical activity into it? If not, how? Why not? And how could this be improved moving forward? So Anna, I think I'm done. I'm going to end the old show. And thank you so much, everyone, for listening to me. If you have any questions, then fire away. But thank you very much.
Thank you, Jake. That was brilliant. Thank you. Despite the Wi-Fi difficulties, I felt like that was a really clear and thought-provoking presentation for all of us. Thank you. And thank you as well for really helping us see the relevance to occupational therapy and posing those discovery questions at the end, which will hopefully really help to get people thinking and to get discussions started. I thought, if you're okay, I might just open to general questions first, if that's all right, Jake, before we go on to discovery questions. Liz, I can see you've got your hand up as well. Was there something you wanted to ask? Kick us off.
I've got quite a few general questions actually, but I'm aware that I could potentially hog the whole time. So
Okay.
I will try and contain myself. Jake, we might need to have another discussion afterwards at some point. But before I ask my general questions, I put all the questions that Jake has asked on an ideas board, and I've just posted it on the chat. And so I think we will go on to either have breakout sessions where we can discuss in more detail. But even if people want to add to these questions after we close tonight, I mean, because you've not got anything better to do, then you will find the link on the ideas board really easy, hopefully, to use and answer them. which will provide you, Jake, hopefully with some nice answers. Shall I ask my first question, or shall I?
Do people want to raise hands if they've got questions, and then I'll sort of know who to come to and how many we've got, and we can sort of factor in time a bit, Liz, to make sure you don't hog the floor, as you said. You might be on your own, Liz, at the look at the moment, so you might be welcome to hog the floor. Oh no, Andy's got some questions too. You've got some competition now. Go on, Liz, kick us off. Because sometimes other people asking questions then spurs on questions in others, doesn't it?
Yeah, okay. So my first question is, are the learning resources that you've mentioned tonight, are they all freely available, Jake?
They are, Liz, and I've just added a link to the presentation in the group chat. So on every picture, or the majority of pictures, I've linked it to the direct training resource. So it should be easy for anyone who wants to access any of the training to just sign up, log in. I think you just need to provide the usual email password to sign up and enroll in these courses.
Thank you. I'll just sneak my second question in, as I've still only got Andy as competition. When in the findings you put, sorry, just before I say this, you mentioned a few times, or you said during your presentation, oh, you might already know this. When I've talked to a lot of our OTs about physical activity, they are actually at so many of them are actually at the start of their understanding around physical activity. So it might be that people are actually just starting to consider this, and so just that may be why people may not ask loads of questions, because it can be quite new for people, in my experience. You mentioned in the findings that there's no standardized learning, and then I thought, is PAC not standardized learning? What would you describe as standardized learning?
So I should have been more clear. That was sort of more in relation to the undergraduate education. In terms of CPD,
right, yeah. There
is a standardized PAC approach, for which I was involved in the review of the revised PAC learning resource. That would be standardized in the sense that there is a slide set that people can sign up and deliver. However, I think it's encouraged to tailor that to your audience as well. So in terms of CPD, there is a relevance, or there is a degree of standardization. However, there's a counter argument to that, in terms of delivering homogenized information isn't relevant necessarily to certain occupations. So if you're going to deliver physical activity training to a GP, for example, is that relevant to an OT? Is that relevant to a physiotherapist? So it's a two-way street in terms of standardization. Yes, there is a degree of standardization in terms of the CPD, but in terms of the undergraduate literature, there is not. It's a drop in where you can, if at all. Whilst there is a commitment by the Council of Deans to incorporate physical activity promotion in medical schools, there's very few case studies of that actually being implemented clearly, which is what we define as standardization. So yeah, apologies for the discrepancies, but that's what we mean by standardization.
Jake, I'm just going to pick up on that. This will probably appear a bit picky, but I'm saying it because I've noticed there's a lot of students on the call that we don't tend to talk in terms of undergraduate education, just because we actually train OTs at master's level as well. We tend to talk about pre-registration education. So when Jake's referring to undergraduate education, what you're actually talking about is kind of pre-registration health education, isn't it? To include master's and undergraduate programs that lead to a professional qualification as an OT or as a physio, or is that right? Am I right in saying that, Jake?
Spot on, Anna, and apologies to any students.
No, that's fine. No, it's just a bit of a picky point, but I just wanted to be clear to the master students that might be on the call that you're talking about their education as well as undergraduate OT programs. Thank you. Shall I go to Andy?
Hello, Jake. I'm Andy. I'm not sure if I may have introduced myself while you're on the call with the Wi-Fi difficulties. So I'm an occupational therapist working with Liz and Anna at the wonderful Sport for Confidence. But I'm also a disabled person. I live with cerebral palsy. I find if I can achieve the CMO guidelines in the week and what have you, and work towards it, it does wonders for my health. So important. So I've really very much enjoyed listening to your presentation today. It's been great. I'm just interested, you know, there's so many questions I think I have. I'm trying to think what to ask, but there's something like a lot of the learning seems to focus around long-term health conditions as opposed to perhaps disabled people or the disabled population. I'm sometimes unsure if they're defined differently or what. I've done the 9-hour course on the e-learning for health, but I felt that perhaps it lacked that focus around disabled people and then supporting people to be active in their everyday occupations, and how you may provide advice perhaps to someone who's not able to move in the traditional sense or what have you, or doesn't feel able to identify with the guidelines that seem, you know, a lot to achieve. You know, I know it's the same guidelines for disabled adults as for adults without disabilities, but I wonder if it really feels that it's something that can be achievable and how we kind of support people with that gap.
Yeah, well, Andy, thank you for your question, and it's one that we've really wrestled with through our research with social workers, but more specifically to this training. Yeah, you're right. There is very limited learning made available to understanding disability as an umbrella term, and whilst long-term health conditions can be disabling, I think if I'm right in understanding, you're referring to other conditions, more well-known defined disabilities, as it were, as opposed to coronary heart disease or diabetes or stroke. Yeah, so there is very limited training within the existing content, which if you've taken part in the e-learning for healthcare, I think you might concur with that. However, it's very easy for someone to understand or have a knowledge of the physical activity guidelines, which is 150 minutes of moderate intensity activity or 75 minutes of vigorous physical activity and 2 days of strength, balance and flexibility training to achieve health benefits. And that message to be communicated to disabled people or people with long-term health conditions, and say you should be achieving 150 minutes of physical activity per week. And to some people, that is completely unrealistic, it's completely unachievable, and that as a message is really insincere and can contribute towards adverse levels of activity, a fear, essentially. So one way that these physical activity guidelines are changing, and the disabled children's and young people guidelines are the first to change through this, has been using co-production to understand how these messages should be communicated. And so a lot of the messaging around that guidance and the guidance that will follow when the reviews come in 2024 and 2025 for the adults and children's guidelines will be about starting at a personal level and building up from your level. So it's trying to provide that person-centered initiative whilst understanding that the evidence supports 150 minutes for long-term health benefits. So rather than that being the utopian aim, it's building up from where you are, your level of your level of ability, your level of activity, slowly to accrue those health benefits, because any activity is better than no activity. And these small movements are the powerful movements. And that's where it comes back to the definition of what physical activity actually is. And that's something we've wrestled with as part of the social work training, is that whilst you may advocate exercise prescription through a gym or a gym program, that isn't right for everyone. And there are other activities, cleaning, gardening, walking your dog, are physical activities. And so it's how we define physical activity is how we define accruing those aggregated minutes per week. And so that's something which I think is, as an OT, whilst I'm not an OT myself, I feel like you as a professional group have a holistic understanding of that, as opposed to a GP who may only have 10 minutes with a patient, and even that language, calling people patients, is dehumanizing. So to small and work with a person's current level of competency and current ability, and building that over time with the interests of what they like to do and how they like to be active, is the message that's missing in the healthcare training at present. But I feel like this is the message that needs to be said. Have I answered your question, Andy?
That's been really helpful. Thanks, Jake. Yeah, no, it's good. I often think, to some of the participants at Sport for Confidence who may, be wheelchair users or what have you, and who may not. Yes, it's really helpful to think about how we need to adjust the messaging to, so that we can deliver the important message about physical activity, but in a way that's meaningful and that they can identify with. Yeah, thank you very much. It's been really helpful.
And that's how the training should be incorporated, and that's how maybe we see that's how moving OT moves forward, is that personalized message as opposed to the generic you need to achieve X amount of minutes for health benefits. And that's something we can have a discussion about moving forward.
That's great. Thanks ever so much, Jake. It's brilliant. Thank you.
I think it is a really relevant point for occupational therapists, actually, Jake and Andy. So I think it's great that question's brought that out, really, because I think as well, one of the things that I get a bit frustrated with, particularly coming from a background in mental health practice, is this sort of rather what I would refer to as rather evangelical approach to promoting physical activity, that it's this sort of universal panacea, where actually those of us that have practiced in areas such as eating disorders know that actually physical activity can be used as a very sort of negative occupation and a very harmful occupation in terms of people's health. So I think it's really helpful to think about, the complexity of well as promoting physical activity and enabling participation in physical activity, because sometimes that might need to come back to more sort of occupational balance type approaches of sort of getting things right for that individual, as you say. I did also want to quickly pick up on Liz's point about some people on the call might just be getting started with physical activity. I think that's a really good point. And I was also just going to say that people might find it helpful to look at the Creek book, the Creek's Occupational Therapy and Mental Health book. There's a chapter in that on physical activity written by someone called Fiona Cole, and that includes a service user kind of reflection at the end of each chapter. And the one on the physical activity chapter is really interesting because it picks up on some of the issues Jake mentions about their experiences of sort of feeling as if physical activity promotion wasn't done very well, shall we say, that they felt quite uncomfortable and under pressure at times in terms of how it was promoted in practice. So again, I think it's really helpful to think through those sort of subtleties of how that practice is undertaken, Jake. So that's a really helpful point. Thank you. Liz, should we come to you again? Sorry. Yeah.
I wanted to comment on, you mentioned the PAC training a few times, the Physical Activity Clinical Champions training. So I wanted to comment on that. But so I'll do that first. Sorry, I'm just getting confused with how much I want to ask you, but what I should prioritise. So the PAC training. So I've kind of been experienced PAC training from a few different angles. So when I was working as a clinician, sort of four or five years ago now or more, so I don't know when it started, but I remember finding out about the training and feeling quite excited because I was keen OT that was really passionate about physical activity, and this was the first sort of evidence-based training that I'd really heard about. And so had the training myself, and also started to try and organise training for other people. And I still do that now, actually. And I know it's kind of just going through a bit of a transitional phase and being owned by another organisation. And so I do promote that training as much as possible. So I'm really positive about the training. I think it's really decent, good quality. I think you leave with lots of really good quality information. But so many conversations I've had with people, and this is something I felt myself, was yes, but so what? And what does that mean for us in practice? Because so many of us know the benefits of physical activity. Yes, it does give you a slightly more in-depth understanding of physical activity and the benefits on our health, other people's health, etc. And so you do come out of it feeling more knowledgeable, but so what? It doesn't change the way that NHS services run, that how NHS services or teams can incorporate physical activity. And so actually we teamed up with the clinical champions and did some joint training together. So from Sport for Confidence and the clinical champions, we did a couple of sets of joint training, one with Sheffield NHS and one with Nottingham, and we just sort of teamed it up. One delivered the training, then two did a bit more of a kind of seeking out their health professionals' experiences, what else they wanted, what would help them get from that training to the next lot. And we got loads of information, and actually we're just kind of, it wasn't a big research piece or anything. It was more like a quality improvement sort of pilot piece. But I'd be interested in talking about that with you a little bit more, and actually where we take that, because I just wondered, what's your experience of that training, and do you agree or disagree with my kind of comment on so what in the nicest possible way?
Well, yes, Liz, let's have that conversation first off. And I'm sure if you've got any snippets that maybe you could share to the audience about where those next steps are leading, that might be quite handy in this conversation. But this scoping review didn't really touch on the PAC culture, as it were, specifically, but based on my own knowledge of PAC and where it's heading, I know a lot of the discussions behind the scenes are to do with a lot of what you've mentioned about the so what. And for me, the so what is about telling the story behind why physical activity is important, more so than the content and the knowledge. It's the grip that entices people to embed that as part of their daily practice. So within that, a lot of the prominent people within PAC are stating that the storytelling and the ability for the patient to describe and explain their experiences of how physical activity might benefit them and might benefit other people, in addition to other professionals sharing their stories of how physical activity is a tool as well as a behaviour to improve health conditions and physical activity behaviour and reduce health inequalities, is the way forward, as opposed to what we've outlined in the scoping review, which is that very epidemiological, biopsychosocial, physiological approach to physical activity of you do this, you get that, in that exchange model. It's more so than that. It's a cultural, there's social determinants, there's health determinants. It's why maybe your occupational hat is so beneficial to PAC moving forward, because you have that understanding of the wider determinants of health and how that can benefit people in their daily lives, essentially, rather than saying, it's good for you, because there's many things that are good for you, but you don't end up doing them, do you? What is important is to embed this as a culture as well. And I've never actually taken part in the PAC training, as I'm not a healthcare professional, I'm not a social worker, I'm not an OT, so I'm not eligible, as it were, but I just have an understanding of the inner workings of it. And I feel like it's a cultural movement in terms of you don't want 20 people or however many people who take part in this PAC training to walk away thinking, yeah, it's quite good. You want this to be an established culture within the whole profession to say this is really important, not only for the people that we support, but actually for your own health behavior as well, because it might make you think and reflect on your own behaviors moving forward as well. And ensuring that physical activity is a core tenet of your learning and of your being, rather than just a nice bolt on, if that makes sense.
Yeah, no, that's really interesting. Thank you. I think we've tried to incorporate participant stories as part of our kind of part B as such. What can we deliver that's additional? And we incorporated that. However, that's great, but the questions that came up for us from numerous different professionals were lots of different things, like we as clinicians or activity workers or whoever, we want to do this, we believe in this, but actually how do we go about it, or where do we stand in terms of risk, what's our scope of practice, what do we need to get signed off or not, and that fear of, is this my role? And so lots of things came up like that, as well as kind of like just general sort of service blockers, like we want to do this, but our manager's not up for it. It's not part of the team's goals or whatever. I did hear once that an NHS organisation had a sequin attached, so therefore money attached to embedding physical activity. However, it still wasn't. There's just so many barriers that I think even if we trained our clinicians and they were all super trained up, super knowledgeable, it's still, obviously that alone isn't enough, I guess. Yeah.
This might be a question back to your questions then, Liz, but first off, like the one snippet that you did mention about risk, if you go on to Moving Medicine, which is part of Moving Healthcare Professionals, it's a free website. There is a risk statement or a consensus statement on risk that states that there is no adverse health impact, or that the health benefits of being physically active outweighs the negatives of being physically active. So anyone on the call, that is your MO, that is your justification, that is the weight off your shoulders to say that physical activity, the benefits outweigh the negatives. And that goes all the way back to what Anne was saying about, and that conversation about starting small and adding it up rather than jumping straight into the 150 minutes of the recommended guidance. It's all context specific, it's all person specific. But back to you, Liz, like I think one way that this gets embedded, and this is where PAC can be really beneficial, is working with people like Sport for Confidence and actually embedding this in these organizations, which are the social movements, alongside clinical practice. So how have you found, what's your experience been of working with PAC or with people involved in PAC and your position at Sport for Confidence? And is there a difference there? Is this a way in?
Well, I mean, I just think we need to have further conversations after this, because I just think we've got loads of information from clinicians, OTs, not just OTs actually, loads of people recorded, and experience within our team that we can add to this conversation. And so, yes, I think that PAC needs to work with not just Sport for Confidence, but with local organisations. In we started incorporating active partnerships and making sure that they were part and parcel with the full version of PAC. It's a 3-hour. It's meant to be a 3-hour training course. So this is a problem in itself. Is one, that's great. And so when the 3-hour training course is delivered and therefore that end bit is prioritised as well, which is more about looking at local opportunities, having them maybe more collaboration with the trainer and the clinicians themselves. However, what normally happens, sorry, from my limited experience, is that the first hour is prioritised because that's all that the NHS have got time for. So therefore, it doesn't go in depth enough. And we don't have them meaningful conversations around how does this work in your team, etc. And so, and actually, PAC, sorry, I feel like I'm now going to, on a recorded call, start slagging off PAC. I'll try and calm myself down. What was I going to say about PAC? PAC, standardised in the way it is, great on the one hand, but really inflexible on another. And so I'm working with, again, Sheffield and Nottingham are saying to me, really want PAC. However, well, actually, what we've got time for in reality is 30 minutes, and we don't want all PAC. What we want is something really tailored to our team. And so that's what we're doing in Sport for Confidence, is actually working directly with the team, adjusting PAC, adjusting the evidence rather than just in PAC, and tailoring it to their team. And that's what I think NHS services want, is something much more tailored to them.
I completely agree.
I have got a few more hands up. So I just want to move on, if that's okay. But good idea to connect off after tonight, you two, and maybe have some more detailed conversations about PAC. I have posted the ideas for people are asking what is PAC, the Physical Activity Champions Training. Do you want to say a bit about it, Liz?
Yeah, I will send out the link. I'll put the link in the chat. You
can put it in the chat, yeah, because people are asking what it is.
And people can email me afterwards, and I can happily talk to them about it.
Okay. I have put the ideas board link in the chat again. If people can contribute to that before we go, I'd be really, really grateful. I can see some people are adding some bits now. Thank you. All right, if I go to Zoe first and then back to you, Andy, with another question, is that all right? Great, thank you, Zoe.
Hi, yeah, it's what, can you hear me okay?
Yeah, we can hear you fine.
Yeah, brilliant. It's more of a comment really, because I work in community mental health, and the biggest sort of challenge and barrier with trying to get people linked into any sort of physical activity is the social determinants. It is their psychological, so the internal, intrinsic sort of barriers, but the extrinsic. It's, you find when you link in with different organisations, or even going out for a walk, that can really sort of feed into their feelings of not feeling included, of not feeling connected, and you really have to break that down as a professional. And that's actually my main role. So it's not usually selling the benefits of physical activity, it's actually trying to break down those challenges for that individual. So I quite liked the LEAP acronym. I have never heard of that before, but that's exactly how I practice.
Zoe's also doing a very interesting piece of work at the moment, aren't you, Zoe? Do you want to say a bit about that?
Well, I'm exploring how we can use a park run from an occupational perspective, really, and how inclusive is it? Because obviously part of the central tenets of park run is that it's very inclusive, and I really want to explore, well, how inclusive it is, and from a mental health perspective, sort of mainly. So yeah, doing a literature review, but probably we'll build on to something else, as Anna's trying to persuade me to do.
Always. Thank you, Zoe. Was that all from you, Zoe? You all right if we go to Andy?
Yeah, that's great. Yeah.
Over to you, Andy. Thank you. Thanks for people adding to the ideas board. That's brilliant. I can see it coming up on my other screen.
Thanks, Jake. It's great to. I wish it wasn't. We didn't have 20 minutes left. I wish we had hours left. But time is as it is. What was I was just a couple of questions really, Jake. I've just seen a comment from Anna Maria in the chat and talking about university, and it's not in a domain and in the modules the occupational therapist study, and I'm wondering, having studied fairly recently, and I'm thinking back to my course, how it can be incorporated, given physical activity perhaps is seen as the physiotherapist's domain, and we as OTs are we're the ones that can think in a biopsychosocial with the biopsychosocial hat, and then but perhaps I wonder that the physical health still sits within that hat, but it's I don't know, I'm trying to think how I articulate my question, but is it so physio? Yeah, but it's not for physiotherapists or those, perhaps exercise professionals. Perhaps it's yeah, because there's the opportunity there for occupational therapists with the wider determinants of health and the value and the skills and knowledge we can bring us with our focus, that the opportunities we can use to help service users, participants, patients, whatever public, whatever. I don't know if you have a thought there about how with the profession it's so diverse.
So,
sorry,
Andy, if I'm hearing you right, are you talking about those people in? Correct me if I'm wrong, Anna. Is this the readiness for practice or the students that you're referring to, Andy, about how this is sort of incorporated into their education?
I think so. But also, Jake, I'm also thinking of perhaps of those in education who have been many years in practice and find it difficult to perhaps so focused on their scope of practice occupation to then think about fitting physical activity into that mindset when that's a physiotherapists, and we as focus on occupation, and that's somehow very different, but actually physical activity is very much an important part of
yeah,
that. Yeah, sorry.
It's exactly the same conversation we've had as part of moving social work, in terms of those who are pre-registration, sort of entering that readiness for practice, or those who are already qualified, who are years down the line in practice, working in multidisciplinary teams or as individuals. I'm not familiar with the actual specific domains of occupational therapy. It's not my field, but we have the same conversations. That's not really my thing. That's the physio's job. Or I don't talk about physical activity. That's a nurse. Why would I talk about that? And that's where moving OTs, moving forward, this is where these conversations are so important, and contributing to the ideas board is so important, to say for those who are in pre-registration stages of undergraduate, masters, postgraduate training, to say, okay, this really fits in this module that I'm studying, or this really relates to some of the key contents that I'm learning about. I feel like physical activity would really fit quite well in there. And for those who are already qualified, those who are already in practice, the importance and the value of CPD training and education moving forward is to highlight that physical activity is not a bolt-on. It is a culture. It is a key tenet that we can embed in everyday routine practice, rather than thinking it as an additional thing to consider. It is a key determinant of health and well-being. So how do we progress the occupational culture whereby embedding physical activity into those conversations as routine, as standard, like this is how we think, this is how we enact, we practice through promotion of activity, which from my limited understanding of occupational therapy, I think you already do. However, it's the mindset, it's switching the mindset of thinking, I do this, and because I do this, I can do it more, as opposed to it thinking, right, okay, going in to see people and supporting people, I need to mention this.
I think
It's like I was talking
sometimes as well, the issue, just to pick up on your point there, Jake, is about language for occupational therapists, and I wonder for social workers as well, because many moons ago, when Brett first produced the social work guide around physical activities, Sport for Confidence were actually commissioned, and I went into social work bases and disseminated the guide. And a lot of people afterwards said to me, oh, because I started with a discussion about what constitutes physical activity. And it's interesting, you started with that as well, and particularly with Joe's definition. Because people were like, oh, okay, I hadn't really thought, I thought you meant sport and going to the gym. I didn't really think you meant things like gardening and hanging out the washing and climbing up and down the stairs. I think sometimes maybe not for occupational therapists, it's also about sort of realizing that they might already be doing it, almost like you're saying, as part of sort of other activities that they're not necessarily conceptualizing as physical activity.
that's the message completely, Anna. And Andy, I hope that answers your question about how we change that. It's the culture and it's the language that we use. And I hope, if anything, at the end of this call, people might feel more confident in their own ability to say, I am a physically active person. You know, I'm not a sporty person, or I don't take part in exercise, or I don't go to the gym, but I love walking my dogs. Or even, depending on your level, if getting up and down the stairs is hard for a person, to recognize that as moderate or vigorous physical activity. Typically, the easiest way that I can describe moderate to vigorous physical activity or vigorous intensity activity to anyone still unfamiliar with those terms is something called the talk test. So if you can still do something whilst talking, deem that as moderate intensity activity. Whereas if it causes you to be a bit out of breath, ramp that up as vigorous. Okay. And then you can contribute that towards your understanding of how I'm being active. And the final comment, physical activity versus physical exercise, that's case in point. That is exactly it. It's moving away from exercise and sport, that narrative, towards movement and activity, which the World Health Organization definition does state movement, but it's wrapped in this energy expenditure, movement by skeletal muscles, whereas Joe's definition is much more culturally aware and speaks to the person. And that's what we need to incorporate, Andy, is the person. The person at the center of any care is the most important thing. So what's important to that person?
Speaking like an OT then, Jake.
Yeah. Be an honorary one, Jake.
Yeah.
If I can come next time, I'd like that. Yeah, very much.
Thank you, Jake. That's very helpful. Thanks so much.
We've got about 10 minutes left, so it's brilliant. So many people are contributing to the ideas board. Do keep the comments coming, because that's really useful feedback for all of us. And it's brilliant to see some of the things that you're posting appearing. But any further questions, discussion points that people wanted? If people feel more comfortable, do just add them to the chat. That's absolutely fine, and I can read them out to Jake. Andy again.
Hi, Jake. Third question. So recently, members of Sport for Confidence, we attended an inclusion summit around sport and physical activity and exercise. But I think at that summit, we were aware that it was very much around sport, physical activity. And I just wondered how those domains can help link with healthcare, all those professions, and how we can work together. I mean, I think a lot of people still don't know what occupational therapy is or does, or what can help people achieve. But yeah, I mean, because I know there are courses out there that I've studied them, you know, around physical disability and exercise and what have you. But lots of health exercise professionals or people who work in the fitness industry don't know about disability, and I think there's a great opportunity to help them to connect with healthcare professionals and OTs and perhaps social workers to help promote opportunities if people want to be physically active in that environment, or or
Andy, I'm so I missed the
Yeah.
first part of your question, so I don't quite have the context of
Yeah,
your point.
it was so there was we've been to the conference recently, which was around inclusion, and I think a lot of it was around sport exercise professionals being more inclusive. But if there's opportunities to connect and work together and work with healthcare professionals, that I feel's perhaps an opportunity that could be help people to be more active, whether they choose to be active in a gym environment or leisure environment or not. But it's what can be done. Jake, do you feel to link the two together, given that it can be a space where people think about being more active, or perhaps some people think about being more active?
Yeah, I think that space and those kind of conversations at conferences are great when they're at conferences, because it does disseminate the message in that microclimate. And I think you're asking about how we spread that a little bit wider, spread the net, cast it a bit further. For me, and part of the work we do with Moving Social Work has been a lot of work with Disability Rights UK, and in particular Get Yourself Active, which we have had fantastic experience working closely with them. And I think that partnership working, for me personally, is the only way forward, is working in that multi-agency approach. And that is essentially the philosophy of making every contact count, is spreading the message of physical activity across professions and across workforces, with that sort of community sort of activism and the ground up kind of approach, rather it be the top down physical activity is good for you, you should all go do it. Understanding why, understanding how, and relating back to those determinants of health and professional practice is really the way to go. So for me, from our experience of Moving Social Work, is about the relationship building before the training, if that makes sense, is building those networks, building those relationships. So like me now, so we know Anna, Brett knows Anna, and I've met Liz through Anna and Liz through Brett, and Liz is part of the advisory board on Moving Social Work, but she's not a social worker. That's it's bridging those gaps or bridging those connections that is the way forward, really, because a lot of us are doing work in the same space in different contexts. So it's sharing that learning and sharing how we can all work together, but with that sort of real grassroots community grounding, for me, would make the real social change. Just remiss of time, I've just put my email in the chat box. If anyone does want to email me privately, that's absolutely fine. But if not, stick any questions further on the ideas board. But thank you, Andy. Great question. I hope I've answered it.
Yeah, thanks, Jake. It's like I often think people like often in the sport physical activity industry can be enthusiastic about disability, but they're not necessarily have the understanding or the confidence to be able to support people with disabilities, or that knowledge of how to connect with healthcare professionals, or to be able to make being physically active part of somebody's everyday life, whether they choose to be physically active in a leisure space or not. But yeah,
I think
Liz, you might add to that.
Sorry,
Yeah.
I was just going to jump in because I know that me and Andy have talked about this quite a bit, and because we went to the Include Summit together, and it's just something that we're learning, I think, because we're obviously from a health sort of background, used to working in the NHS, but now with Sport for Confidence find ourselves also in the sport world. And it's so amazing. You go to these sport conferences and we're the only healthcare professionals there, more or less. And you're like, oh, isn't it a shame there's not more healthcare professionals here, because we're all talking about the same thing, but we're not really working together. And then you go, I went to a Sport England conference once, and in the same building on the same day at the same time, there was an NHS conference, and I was like, oh damn, isn't this an opportunity we could have connected? And I think that lack of collaboration between the health and sports sector really needs to change, because I agree with, I think, both your comment, Andy, and your comment, Jake, is actually that collaboration and connection so important.
Really
Thanks
good
both.
points,
Yeah.
thank you. Great, thank you. Any final questions? Yep, Marco. Hi, Marco. Marco's one of our international participants, Jake. He's joining us from Italy. We're always jealous of the weather in the back of Marco's calls. Although we're not seeing your balcony today. I think last time we could see your window or balcony. Never mind.
But now is dark for us because it's 9 o'clock p.m. So
okay.
Yes. Thank you, Jake, for your presentation. I think it was really interesting. I just want to add a comment about the importance of physical activity, not just from the physical point of view, but also from the social point of view, in particular for people and children with disability, because you currently spoke about the intensity of the physical activity, the importance of the intensity of training for physical benefits. But I also think that it is important to consider the social and the emotional benefits of this kind of activities. So it is also, I think, for children with disability, important to have just also few sessions, but together with other children, with their peers, and this can also have important social and social benefits. Yes.
I completely agree, Marco, and I think I'm the one who's doing the working in the garden or showing the view behind, so I'll represent for you this time. But I would urge you to have a look at the Chief Medical Officer's Physical Activity Guideline infographics for children, and then the separate graphic for disabled children and young people. And with the two, have a look at the language and the type of language that's been used. And I think you'll see that the most recent infographic for disabled children and young people in terms of physical activity guidelines, there is a severe change in use of language around socialization, finding what's fun, and feeling included and part of something. And that's the sea change that I feel needs to happen. So if you've not seen those guidelines, I know if you're in Italy at the moment, is that right?
Yes. Yes.
So I'm not sure if the UK physical activity guidelines are relevant to where you are at the moment, but have a look and see what they're like, to see how the language is evolving, how that language is changing. I completely agree with your point.
Thank you.
Thank you. Thanks, Marco. We have come to time now, so I am going to finish off. In terms of ideas board, Liz, it will still be open for people to contribute after we finish tonight. So if you want to wait and do that a bit afterwards, do please feel free to do that. It's brilliant to have your feedback and comments to gain a better understanding of where you're at in relation to physical activity. So thank you for that. I want to say a massive thank you to Jake for this evening, and also to you all for coming along, because it's great to see you all, but particularly thank you, Jake, for providing such a kind of clear, comprehensive presentation, and also for providing brilliant answers to the questions as well, because it's taken us really comfortably to time. Thank you. So thank you. Lots of applause here in the reactions, Jake.
Oh, well, I'm sorry my internet was no good, so hopefully fibre optic will be in when we next have the chance to communicate. But yeah, this is really exciting. I was
impressed you stuck with it and have been out. It's a good job it's good weather tonight, isn't it, Jake? If it was raining, we might really have been in trouble.
Yeah, Big props to my neighbour as well for letting me steal his Wi-Fi.
Yes, a big thanks to Jake's neighbour. He definitely deserves a thank you. Thank you, everyone. Do email Jake if you'd like. He's kindly put his email in the chat. So, or equally, if you want, make contact with us at Sport for Confidence if you want to have a further conversations about anything tonight. But yeah, massive thank you, everyone, for coming. Thank you.
Thank
Thank you, guys.
Oh, someone's cat, I think.